Hello, I'm Jan Leifman.
Hi, I'm Gayatri from Menon.
Welcome to MedNews Week Conference, where we feature presentations by medicine's global leaders. Today we have an amazing keynote speaker in Dr. Pavani Chalasani. Dr. Chalasani currently serves as the chief of the section for Breast Medical Oncology and is also an associate professor of medicine with tenure at the University of Arizona Cancer Center.
In today's presentation, Dr. Chalasani discusses the current treatment paradigm for metastatic triple-negative breast cancer.
Did you know that Dr. Chalasani is an internationally renowned investigator that has led many late-stage clinical trials to investigate novel therapies against metastatic and triple-negative breast cancer? She's also the recipient of many prestigious awards, including the Inside Tucson Business Influential Health and Medical Leader Award and the Arizona Health Science Center Career Development Award.
What an inspirational pioneer in the field of oncology.
So let's tune in. Let's tune in and learn from this global leader.
It's my pleasure to present current updates on the treatment paradigm for metastatic triple-negative breast cancer. I work at the University of Arizona Cancer Center here in sunny Tucson, where it is almost 100 degrees today. So on that note, these are my disclosures. There's no conflict with the talk that I'm giving today. Just a brief outline. I'm going to just go over some background just to get everyone up to speed and just have a baseline about some triple-negative breast cancer, then go over immunotherapy and the antibody drug conjugates, which are paving the way for new therapies in triple-negative breast cancer. As everyone is aware, triple-negative breast cancer is the biology where we have estrogen, progesterone, and the HER2 negative, the three known targets or triggers for breast cancer. They are not evaluated on the tumor specimen. So when the expression of the estrogen receptor, progesterone, and the HER2 are negative, that's when we call it triple negative. In general, the incidence of the breast cancer, when we talk about estrogen receptor positive or hormone receptor positive is the group that we commonly refer to that, it's about 65 to 80%. Whereas HER2 negative is more about 25%, about 20 to 25%, and triple negative, we call it as 10 to 20%. Now, there may be some shift in terminology with the new data which was presented in the HER2 low category. So there may be some changes coming up in our definitions and how we divide or subtype our tumors. But in general, for now, this is how we broadly define our tumor biologies. Now, triple-negative breast cancer, while we group it under one type, like the estrogen, progesterone, the HER2 are negative, they're still a very heterogeneous tumors. There have been multiple sequencing and other profiling studies which have shown that there are basal-like subtypes, there are androgen receptor-rich, mesenchymal, immune-activated, basal-like immune-suppressed. So there are multiple subtypes, and there have been some beautiful papers which have been published demonstrating, the various the subtypes and how these are just intrinsically so different. And how do they matter? Because the responses to treatments matter, how their prognosis matters. So these are all significantly important for us to understand that even though they are all lumped together one, and that is also critical for clinical trials, because all of them are put under one umbrella, but there is just a lot more heterogeneity in these tumor types. Now, the general characteristics, it's more common in young women, African-American women, and those who have BRCA1 mutations. It is very aggressive with a high risk of recurrence. And we say pretty much most of the tumors, if they tend to recur, it happens within the first 3 to 5 years. Most patients, they are diagnosed early, so it's stage 2 to 3 at diagnosis. And we tend to do more neoadjuvant treatments, especially to understand the prognosis and to assess, identify those high-risk patients who are going to have a high risk of recurrence and develop distant metastatic disease, which is terminal or not curable for the majority of patients. And we have a way to assess that, and that is called PCR, or pathological complete response. That one correlates with the risk of disease-free survival very well. So we try to get that additional prognostic information to figure out how our patients are going to do long term. The 5-year survival rates for triple negative breast cancer, this is based on the SEER stage for about 2011 to 2017. But for distant metastasis, as you can see, for localized, it's about 91%, whereas for distant, it goes down as the stage increases, it goes down, but for distant metastasis, it's about 12%. So, but the clinical outcomes are improving. So there is definitely improvements we are making. And that is by increasing the pathological complete response rates, especially with the combination of immunotherapies and chemotherapy combinations. We have adjuvant capecitabine, we have olaparib in patients who have BRCA1 or 2 mutations. And we are trying to develop more effective targeted agents in metastatic triple negatives, especially with immunotherapies, PARP inhibitors, and TROP1, and ADCs. So these actually are paving the way for new treatments to come on, and there's a lot of excitement in this field. Huge, improvements are still essential, but I think we are making slow progress. With that background, I'm just going to jump into immunotherapy, the first things. So one of the key papers which was published and which is currently the standard of care is that what we call as the Keynote 355 study, and that is pembrolizumab plus chemotherapy versus placebo versus chemotherapy for patients who have untreated, locally recurrent, inoperable, or metastatic triple negative. This was a randomized study, placebo-controlled, double-blind phase 3 trial done over 210 sites over 29 countries globally. So all the patients, about 1,300 or about 1,400 patients, were randomized 2:1. I just put a snippet of the whole big randomization scheme and a very busy picture in the manuscript. But the reason I've just put this little snippet is overall, 372 patients were screened, but the final patient population was about 850 patients. They were assigned, like I said, 2:1 for favoring pembrolizumab. So about 566 were assigned to pembro with the chemotherapy versus 281 to placebo with chemotherapy. The key thing that I want to have everyone as a take-home point here is the percentage of PD-L1 positive, and especially it is for the combined positive score. So combined positive score is the number of PD-L1 staining cells, which is the tumor cells, lymphocytes, and macrophages, divided by the total number of viable tumor cells, which is multiplied by 100. So if the score is over 10 versus over 1, and they try to stratify it. So the randomization was stratified based on the type of chemotherapy, and I'll go over the chemotherapy backbone here in a second. The PD-L1 expression as baseline, and they did that by combined positive score of greater than 1 or less than 1, and previous treatments with the same class of chemotherapy in the neoadjuvant or the adjuvant setting, yes or no. The key primary endpoints were progression-free survival and overall survival. They had dual primary efficacy endpoints for this trial. And mainly they did that was PD-L1 CPS of more than 10, then CPS of 1 or more, and then the intent to treat. So they had this hierarchical staining. So if it was positive 1, then they would go to the next category and group to analyze. And if that was positive, then they would go to the following category. And if one of them was negative, then the following analysis would not be done. So among all the approximately 850 patients, as we can see, 25% had a PD-L1 less than 1, and 75% had more than that. And among those, around 38% had about the PD-L1 of CPS 10 or more. Okay, so this study was primarily done in 2017, 2018, and like I said, about 1,400 patients were screened and 850 were randomized. And the first interim analysis, the data cutoff was in 2019, and they presented data. That was the first study which was presented, and it's, like I said, subsequently published in Lancet. And before going to the deep results, I do want to kind of just go over some of the disease characteristics of the patient population. So these were obviously patients with almost like first-line metastatic. So they could either have de novo metastatic disease or have recurrent or metastatic disease. And the disease-free interval from the diagnosis. So about a third of patients had de novo metastasis. Less than 12 months, from their completion of their systemic therapies. Radiation therapy was not counted. So whenever they finished their systemic therapies, whether it was neoadjuvant or adjuvant, Less than 20%, 12 months was about 20%, and it was pretty equally distributed among both groups. And then more than 12 months was about half of the patient population. The other thing about the patient population that we really need to understand is among those who had metastatic or recurrent, distant metastasis was the most common, whereas locally inoperable was about 3 to 6%. The chemotherapy, so the chemotherapy backbone, which was used in the study, was pembrolizumab with the chemotherapy versus chemo of physician choice with the placebo. And the chemotherapy choices were either nab-paclitaxel or Abraxane, paclitaxel or gemcitabine carboplatin. The number of previous treatments with the same class of drugs was about 20%, and they did not use the same class in about 79%. But as you can see, the majority of them did get more than half, and that was across all subgroups, was gemcitabine carboplatin. Paclitaxel together, but the other common one which was used was nab-paclitaxel. The previous neoadjuvant or adjuvant, as it is demonstrated here, about half got anthracycline-based regimens. 50% or more got a taxane, only about 6%, 6 to 8% got a platinum, and there was other. Because the vast discrepancy was because this was a global study, and there is definitely a variation in the standard regimens. So the main key results which they were presented initially showed for the combined positive score of greater than 10 in the pembrolizumab versus the placebo, there was a difference in the progression-free survival between 9.7 in the pembrolizumab arm versus 5.6 in the placebo arm. In the CPS greater than 1, you just combining the 75% of patients, it was 7.6 by 5.6 months, whereas the intent to treat, and that was pretty much everyone, that combined it to 7.5 to 5.6. Those are pretty similar to that. In the PDL1, and again, this was kind of putting that together, just showing it 5.6 to 7.5, the cutoff of 10, 9.7 by 5.6, favoring the pembro here. And the cutoff of more than 20 is also something they saw, and it was 9.5 and 5.4, kind of similar to 10. Again, trying to establish, it's just very sensitive. Trying to establish what is an optimal or ideal cutoff of the CPS score for us to figure out which patient population, which tumors have this expression would benefit from this treatment. Obviously, one of the new things we always wonder when a therapy comes up is side effects, and especially with immune-mediated adverse events. And obviously, the immune-mediated ones are significantly higher in the pembro and the chemotherapy arm in about a quarter of patients compared to the placebo, because they were not getting any immunotherapy. They did have chemotherapy-related side effects in both arms. The grade 3 or higher, which actually do end up, holding dose reductions and all those things, happen in about 5% or less, and most of them were thyroid-related events, colitis and skin, but they were about less than 1%, and skin adverse reactions, the really severe grade 3 or higher, were 2%. So that is what the initial reports have been, and that kind of set the standard for us to think, okay, pembrolizumab is active, and that it has shown efficacy. Subsequently, there was a late-breaking abstract of the same study with some final results, and this was presented by Dr. Rugo at ESMO last year. And that what they basically showed was in the population with the CPS score of greater than 10, the addition of pembrolizumab basically significantly reduced the risk of death by almost 27%, and there was a 7-month difference between the arms. And benefits were less pronounced in the other 2 SS population. The median survival was about, in the greater than 1 group, was 17.6 months versus 16 months. So it was not significant. And the intent to treat group was also 17.2 versus 15.5 months. Again, not different, but in the CPS of more than 10, it was significantly different. And this was with the overall survival, which was promising, because that is a gold standard that we really want to shoot for. Most of the times in the metastatic setting, we try to assess for progression-free survival, but we've actually seen more and more therapies now showing overall survival. So I think we can aim for that golden endpoint in that, to show the benefit clearly in that sense. And then again, they also provided an update here at the same time for the progression-free survival, because they had more long-term follow-up. And here the progression-free survival, again, 9.7 versus 5.6 months, similar to what I've just presented. And the objective response rate was improved by 12% with the addition of pembrolizumab. The disease control rate, the other things that they commented on and presented, was 65% with the combination. And the duration of response was also higher for these patients too. Now, following that, we had our last update, or at least so far, one of the update was this was present at San Antonio in December, and this one, the cutoff was about June, and the median time from randomization to the data cutoff was about for 3.5 months. And what they showed was the hazard ratio for the overall survival. And again, in the CPS more than 10 group, as more than 10 subgroup, it was 0.73, and they presented in the greater than 1 subgroup 0.86, and the intent to treat similar to what I was just presenting. The hazard ratios, again, for progression-free survival, again, even though the PFS was good in all those things, definitely the key benefit that they're hitting or seeing is in the subgroup of 10 or more. And this kind of provides support. The CPS of greater than 10 is a reasonable cutoff to define the population of patients with metastatic triple-negative breast cancer who are expected to derive benefit from pembro plus chemotherapy. With that, what about the other immunotherapies, and what about, is there any other studies? In fact, one of the first things which has been approved and has been shown was atezolizumab. So in 2018, with the Impassion 130 trial, that was one of the key studies that actually paved the way for the official entrance of immunotherapy in combination with chemotherapy. And the chemotherapy backbone, which was used in that Impassion 130, is nab-paclitaxel. And this is kind of important for us to focus and realize, and I'll go over that in a minute, why. And that was as the new first-line treatment for patients with metastatic triple-negative breast cancer. That was a randomized trial, about 900 patients, untreated, frontline, first-line metastatic triple-negative. They either received treatment, with nab-paclitaxel, either with atezolizumab or placebo, kind of similar to the pembro in that end. And the co-primary endpoints for this trial were, again, progression-free survival and overall survival in the intended to treat population as well as the PD-L1. We have to remember for the atezolizumab to use the PD-L1 that they test, they use a clone with SP142, whereas with the pembrolizumab, it's a different clone that they use for testing. So about 1,200, it's a busy slide, but I'll just go over quickly. About 900 were randomized 1:1. So that is one of the key differences. And what they showed was the initial results actually demonstrated a benefit in the progression-free survival in the intent to treat population. And that was about 7.2 versus 5.5 months. And in the PD-L1 positive, which is 7.5 versus 5. That was one of the first publications and the presentations, actually, which came out, which showed that there was a benefit and it reached a statistical significant levels, but it was about 2 months, 2.5 months. The overall survival did not reach the significance initially, but but then they started actually showing there was a trend, and it finally did hit. It was 25 months in the atezolizumab plus the nab-paclitaxel versus 18 months in the placebo nab-paclitaxel, especially in the PD-L1 subgroup. However, it was powered for the intent to treat population and not the PD-L1. So it was it was not formally not allowed to be tested because of the statistical plan, but that is what it showed was in the PD-L1 positive subgroup, there is a clear overall survival with almost a 7-month. And that, like I said, that is important. And based on that data, actually, the combination of atezolizumab and nab-paclitaxel was approved by FDA as for use in first-line therapy for metastatic triple-negative breast cancer with the PD-L1 positive expression. Now, because nab-paclitaxel for the access is there, they did recommend getting a confirmatory study, and that was what led to Impassion 131, and that was the subsequent study which was again presented in 2020. And this one, again, similarly, phase 3 double-blind placebo-controlled study. This enrolled about 650 patients. Again, metastatic or unresectable, locally advanced triple-negative breast cancer, and no prior chemotherapies or targeted therapies for advanced disease. So patients were randomized to either weekly paclitaxel here. And so paclitaxel is different from the nab-paclitaxel, and I'm sure most of you guys are aware because of the pre-medications that we use. But here, the main the chemotherapy backbone was paclitaxel. And again, it was either atezo versus placebo in a 28-day schedule. The main thing was differing was the primary endpoint was progression-free survival, but it was investigator assessed. And it followed the hierarchical testing, like similarly to the one that I mentioned earlier in the Keynote 355 study, that if they meet the first the endpoint, that was triggers to get the second endpoint to be done. First, they were going to do in the PD-L1 positive population. If that was positive, that would actually trigger the intent to treat population. The secondary endpoints were overall survival, but that would be only formally tested, like I said, in the hierarchical testing design, only if the primary endpoint was positive. This study actually was negative. I mean, there was no difference, and it was a surprise, and it's also very humbling to know that we need to study more. I mean, not everything is a clear-cut answer, and we just need to investigate that. So I'm going to kind of present both these trials side by side just to know what the key differences were and what can potentially explain some of the things which came up from this study. And so, the patient population was slightly different. Obviously, Impassion 130 had, higher sample size compared to Impassion 131, but first-line metastatic triple negative in both categories. Both of them were randomized, but this one 1:1 and this one was 2:1. It was both of them were placebo controlled. It was atezo or placebo combined with nab-paclitaxel, whereas here it was paclitaxel. The primary endpoint, again, we talked about the hierarchical design in both. The PFS in the PD-L1 positive intervention versus control was 7.5 months, like I said, and versus 5 months, and here it was 6 versus 5.7. Whereas in the intent to treat, again, overall it was the same, but here it was pretty similar, 5.7 to 5. Overall survival, again, this was 25 versus the 18 months, which, the 7-month difference, which got all of us excited. Here it was 22, and actually the control arm did better in this, 28 months. The other one was in the intent to treat, again, it was 21 to 18 months, and that was the whole population in the Impassion 130. Whereas again, it was 19 and the control arm actually numerically did better. And that was concerning. Now, if you think about what were the other key differences, I mean, the median age was kind of similar all across. The PD-L1 positivity status of the number of patients who were enrolled with those tumors, pretty, similar. I wouldn't say that's much different. Those with liver metastasis, thinking about if you are enrolling patients with more sicker patients on one, and that is why the results were there. So they looked at liver metastasis that was similar, in both studies, and we can think more than 3 metastatic sites was pretty even. Now, prior taxane treatments, prior anthracycline treatments, again, to know if there is a more intrinsic resistance or these are high-risk tumor. How many were de novo triple negative? Numerically, it's a little bit more so in Impassion, but again, not that much different. The use of concomitant steroids, as everyone is aware, because immunotherapy, we are trying to stimulate the autoimmune or immune system. So giving steroids is kind of counterintuitive, and it actually acts against. So that is the only thing. But for the most part, for the paclitaxel, they got about 8 to 10 milligrams of dexamethasone. And that was at least for the first 2 infusions. They do not have data subsequently how many patients did continue to get the steroids, because that is a medication, and paclitaxel does have pretty significant infusion reactions now. So, but that is what the differences was. The other things we really don't know is there have been some studies which did show that nab-paclitaxel was slightly better than paclitaxel, even though it was not significantly different, and we still use both of them, but the response rates were higher. Is that kind of what drove in the Impassion 130 versus 131? We do not know. The other status information that we do not have is the number of patients who have BRCA status, because those who do have a better responses and prognosis. So were they more in 30 versus 131? And we do not have the data. The other thing is drugs get into our body? What is the BMI? How are they metabolized? So, other lot of questions, that we really don't have the details with. But given that the Impassion 131 was actually negative, and in fact, some of the arms, like I showed the data, the control arms, had numerically better, the atezolizumab was actually, the indication was removed. Currently, for triple negative, the PD-L1 expression threshold for the positivity that combined the CPS score of greater than 10 by immunohistochemistry, pembrolizumab with the chemotherapy, and the backbone is either nab-paclitaxel, which is the albumin-bound paclitaxel, or paclitaxel, or gemcarbo, right? That is the backbone. That is a category 1 indication in the NCCN, and that is a preferred first-line therapy for the tumors which have the positivity. So with that, I'm going to just go switch to the antibody drug conjugates, which have been really exciting to kind of show. And one of the first ones which has been published and approved is sacituzumab govitecan, or SG, to keep it simple. That actually targets a TROP2, and TROP2 is a transmembrane calcium signal transducer. It's linked to tumor progression and poor prognosis. So it is highly expressed in approximately 80% of breast cancer, regardless of subtypes. So in the triple negatives also, it was, because the expression was really high, they did initial phase 1 studies and actually really saw pretty remarkable responses, which kind of accelerated more testing in that subgroup. And it showed benefit, and I'll show in the ASCENT trial, the confirmation trial, and it is approved for patients currently in our clinical practice for metastatic triple negative with either 2 or more treatments or more than 1 in the metastatic setting. The key study, and this is the one, and this, I think they did a great job in just putting the key highlights. NEGM did a really awesome job here. And this one was the ASCENT trial, which got sacituzumab approved too. This was the big global study. Is the phase 3 open label randomized study, and basically it was 530 patients randomized 1:1 for sacituzumab or chemotherapy of physician choice. And basically what it showed was the progression-free survival was 5.6 months compared to 1.7, and these were pretty heavily treated patients too. The grade 3 or 4 toxicities were, numerically a little bit, higher, but they were still tolerable, and this actually improved the progression-free and subsequently overall survival, so this got approved. Now, kind of similar to that, now we have another new kid on the block, and that is datopotamab deruxtecan, and this was actually presented, the last abstract that I'm going to comment was presented by Dr. Ian Kropp at San Antonio in 2021, just last year. And that is antibody drug conjugate directed against the trophoblast, again, TROP2, and that has been showing promise. And this was presented. I'm just going to go with Dato-DXd to make it simple for all of us. These new names are getting to be tongue twisters for most of us. It's an antibody drug conjugate consisting of the humanized anti-TROP2 IgG monoclonal antibody. And it's conjugated to a potent topoisomerase 1 inhibitor payload via a stable linker. And these are, all these antibody drug conjugates. And we have another one which is currently in clinical practice, and that is the trastuzumab deruxtecan. And deruxtecan is a pretty potent payload. So basically, you have the target and the antibody, you have a linker, and then you have the chemotherapy. So these get delivered. These are given IV for right now. Most of them, they're given IV. They attach to the target, antibody or the receptor. They are taken, they're internalized, and then through the lysosomes, and they have enzymes released, the linker or the cleavage is broken and the chemotherapy is delivered. Sometimes based on the potency of the chemotherapy, all they need is their target receptor to be expressed a little bit if there is a really high potency. And then the chemotherapy is also pretty potent. It can actually have diffusion into the surrounding cells. So not every single cell needs to have this high expression. So they're really trying to get potent antibodies with a good, with linkers, and to have this really potent chemotherapy payloads which are acted on so that they can deliver it more targeted And they can also have bystander effect to the other cells surrounding, which do not have or need to have such high expression. So trying to take advantage of both of those things. So deruxtecan, like I said, trastuzumab deruxtecan is actually approved, and the Destiny-04, which just got presented. Since it was not completely in triple negative, I didn't add on here, but it showed pretty cool results just less than 2 months ago now, or approximately 2 months. So very exciting results there. But this one also, again, showed very promising results. The preliminary results from the phase 1, so the TROPION was a pan-tumor study. It was looking at Dato-DXd against the TROP2. So it was pan-tumor, the non-small cell lung cancer that was presented in ASCO last year, 2021, and the triple negative was also presented, focusing a little bit on ESMO of last year too. And these are the updated results on the triple negative cohort. And what it showed, like I said, it's a phase 1 multi-center. So the dose escalation results, it was given about 6 milligrams per kilogram IV every 3 weeks. But there were 2 patients, I think, before they got on who got a little bit higher dose. But they also had safety and efficacy, objective response rate by RECIST, by blinded independent central review. And what Dr. Kropp actually presented was 43 patients with triple negative breast cancer. They received more than 1 dose of the Dato-DXd. So at least we are able to assess, especially for safety, which is critical for all these new exciting ADCs coming on. But we also have to ensure how is it affecting the normal and what is the side effect profile we are looking at. And with 27 patients, we're actually continuing at the time they did the data cutoff, and 16 patients discontinued treatment because of disease. The median age was about mid-50s. 95%, so majority of the patients had got at least more than two or more than 2 lines of therapy. And what was interesting was at least 7 out of these, or 16%, had prior sacituzumab. Sacituzumab is another TROP2. So again, thinking about the govitecan, maybe the payload, maybe that is different. And again, this is something we need to look and develop into to understand about the patient populations and the prior treatments, as all these interesting new treatments are coming up. But then how do we sequence it, or things like that? Do we have data? We are not, but we also have to look into trials like this, where here patients got sacituzumab, govitecan, and then the Dato-DXd did show benefit. So I think things we need to understand more, but it's very interesting. So maybe showing, because they have different payloads, that there is still role for TROP2 antibodies, but we, more studies, and we need more things too. The median duration of treatment was 2.8 months. Among the 38 patients who were evaluable for response, the response rate was about 49%, with 15 of them were confirmed. 3, they were still waiting for by central review, 15 based on the indicator assessment too. The disease control rate was about 5%, and the median time response was about 1.3 months, so about 2 cycles. There were a lot of treatment, like I said. The main thing was treatment emergent adverse events, and those are very critical for us to keep an eye out for and to understand. Pretty much all they saw some kind of adverse event, but the most important ones, if they were more than 30% or grade 3 or more, nausea, stomatitis, alopecia, and this is important. It's important for us to know, because those are critical side effects, for a lot of women and who are undergoing treatments and things too. So these are all important clinical meaningful side effects too. Nausea, stomatitis, alopecia, vomiting, and fatigue. So the preliminary results show that Dato-DXd demonstrates promising anti-tumor activity with manageable safety profile in patients with the previously treated or advanced metastatic triple negative. Confirmatory studies are warranted more, obviously. So hopefully we are looking forward to more studies. And briefly, like I said, at ASCO this year, we had data presented on Destiny-04 study about the trastuzumab deruxtecan and the HER2 low. So as I mentioned earlier, triple negatives where the estrogen, progesterone, and the HER2 are all negative. And the HER2 negative is basically by immunohistochemistry. So it is, by immunohistochemistry, the classification is 0, 1 plus, 2 plus, or 3 plus. 3 plus is positive. 0, 1, and 2, 0 is negative, including 1 and 2. But if they are, most of the places do what we call as a confirmation, like FISH. So generally not for 1+, 2+, it's supposed to be equivocal, and then the FISH is recommended by the guidelines. But clinical practice varies with a lot of individual organizations and pathology labs kind of doing FISH as a confirmation for 1 and 2+, more so than 0. And if the FISH is negative, then the tumors would be classified as HER2 negative. But what they have demonstrated was if their immunohistochemistry, the HER2, was either 1 or 2+, and if you used trastuzumab deruxtecan, there was still a benefit in progression-free survival and overall survival. So in the major study, majority of the patients were hormone receptor positive, the HER2 low, but there were about 60+ patients with the triple negative, like the classic triple negative, or at least not classic, I should say. How they are classified as triple negative currently, they were also included, and it did show benefit too. So there's definitely which is going to come too. So with a lot of treatments currently available, how do we go, or how do we manage? And I think for me as a clinician, when all these treatments are coming, the most important things that I want to consider before I go into is, what are the prior treatments? So is it de novo metastatic versus was it a tumor which was seen, and how long was the treatment in the neoadjuvant or the adjuvant setting? Because they actually do demonstrate sensitivity or resistance to therapies, and what were the treatments that we gave? What is the status of BRCA? What is the status of the PD-L1 of the tumor? And those are critical, important from the tumor perspective in the treatment. However, the other essential thing we need to consider is, what are the toxicities that the patients have experienced with the prior chemotherapy? Was the neuropathy so bad that we cannot use one of those as a backbone? What is the performance status? What is the patient's preference and other social aspects? How far do they live? Are they able to make the treatments, and other considerations that we need to go and kind of do that, take into considerations. But the good thing is we are making the right steps in the right directions, I'm hoping, but we need to understand more and go from there. With that, I'm going to open it for questions. And I really want to thank the organizers for inviting me to give this talk.